All right, so today, thank you for joining us. We will have the Diabetic Foot Care Strategies for Primary Care, Part 2, Treatment of Diabetic Foot Ulcers. We're honored to have Dr. Tran here with us. Dr. Tran graduated from Rosalind Franklin University of Medicine in Medicine and Science. He completed his 3 years residency at Mount Sinai Hospital in New York and Veteran Health Administration in San Diego. Dr. Tran is recognized by the American Board of Wound Management and American Board of Podiatric Medicine. He has held teaching appointments for pre-medical students and post-medical residents at various institutions. He is also the past Deputy Chief Clinical Consultant for the Indian Health Service. He is presently a podiatrist with the Veterans Health Administration, and his work interest as a podiatric physician and surgeon has been in the field of wound management and limb preservation. So thank you so much for joining us today, Dr. Tran. I'm going to go ahead and pull up your slides for you, and then I will give you control of the screen. And you should be good to go. Thank you.
Good afternoon, everybody. Thank you so much for joining us today. It's a pleasure to be back with you folks. Today we'll be doing the Diabetic Foot Care Strategies for Primary Care, as stated, and as stated, Part 2, the Podiatry Care and Basic Wound Management. Let's begin. Our objectives will be to identify and evaluate foot abnormalities in people with diabetes, examine basic principles of diabetic foot care and wound management, utilize an interprofessional team strategy to improve foot care outcomes. Let's summarize, though, that if you guys didn't get a chance, Part 1 of the Diabetic Foot Care Strategies was a complete foot evaluation. We identified factors and findings that increased risk for the diabetic foot complications. We demonstrated how to perform a complete diabetic foot examination, and we introduced strategies to prevent diabetic foot complications in the primary care setting. Please review this complete foot care exam video. My name is Dr. Hai Tran, podiatrist with the Veterans Health Administration and formerly with the Indian Health Service. In this video, I will demonstrate a complete diabetic foot exam. Good morning, Ms. Sam. Thank you for coming in today. We will be conducting your annual diabetic foot exam today. Hey, has anything changed in your general health?
No.
Yeah. You doing well otherwise?
Yes.
Begin with inspecting the feet for skin and nail conditions and foot deformities. There's a little bit of dryness that I'm noticing here, but overall the skin looks really good. There's no rashes that I can see, no discolorations that I can see, so very nice. Let me check in between here real quick. That's very good. Everything's intact there. Again, no rashes, no infections, nothing like that. So we're looking for deformities. Some people may have a bunion. You don't seem to have one. Some people have hammer toes that put you at risk for ulcers. And I can see a little curling of your toes here and a little curling of your toes here, but it seems like they're all reducible, meaning that I can straighten your toes up pretty good so they're not arthritically bound. And lastly, I do not see any calluses or pre-ulcerative lesions related to the deformities on you. Evaluate circulation by assessing the pulses in the feet. Begin with a dorsalis pedis pulse. So let me check your pulses here. This is your dorsalis pedis pulse, and I have good pulse sensations there. I'm going to go right behind your ankles and we'll test your posterior tibial pulses, and again, those are doing very well. Test circulation to the feet with the capillary refill test. Press gently on the skin of the toe until it turns white, then release. The test is normal if the pink color returns in less than 3 seconds. Evaluate protective sensation by using the 10-gram monofilament. I'm going to use this little device here. It's called a Sims-Weinstein monofilament, and this is what it looks like. Show the patient the monofilament and demonstrate how it works on the back of your hand and then the patient's hand. I'm going to ask you to close your eyes, and then I'm going to start with this foot here, and we'll see if you can feel it. Please tell me if you can feel it, when you can feel it.
Yes. Yes. I feel that. I do. Yes. Yes.
An alternative to the monofilament test is the Ipswich, or light touch test. And so all I'm going to do is use my finger, very handy tool, and I'm going to touch, and you tell me if you can feel it. Okay?
Okay.
You ready?
Ready.
Close your eyes again. Okay. So I'm going to start right now. Tell me if you can feel this.
Yes.
Tell me if you can feel this.
Yes.
Tell me if you can feel this.
Yes.
We'll go on this side here. Tell me when you can feel it.
Yes. I feel that. I feel that.
Excellent. A 128 hertz tuning fork is used to test vibration sense. And so you can open up your eyes. This is a tuning fork. It's 128 hertz, if that helps you. But you're going to feel, I'm going to hit it, and I'm going to feel some vibration on it. Can you feel the vibration on that right
Yeah.
there? All right, all right. So I'm going to put this right here onto the big toe joint right there, and you're going to feel the vibration. I would like to know when the vibration stops. Putting it right on the knuckle there. You can feel the vibration?
I feel the vibe
Tell me when it stops, please.
now.
Ankle reflex. Test sensory motor function. So what we're going to do is use this here, and we're just going to tap right back here. I expect it to move, but we'll see.
Okay.
You ready?
I'm ready.
All right. 1, 2, 3. There you go. Thank you so much. 1, 2, 3. Excellent. My last test for you for sensation is something called proprioception. So that's something that we know where we are in space, even if our eyes are closed. You ready?
I'm ready.
Basically, I'm going to take your big toe, and I'm going to move it up and down, and then when I stop, you tell me if it's up or down. Okay?
So I got to close my eyes?
One more time. Ready?
Okay.
1, 2, 3. We're going to move it. And now can you tell me if it's up or down?
Up.
Excellent. We'll do the little guy over here. Can you tell me if it's up or down?
Down.
Excellent. Let's go on this side over here, okay? And tell me if it's up or down?
Up.
Excellent. Going up, down, up, down, up, down.
Up.
Excellent, excellent. The complete diabetic foot exam is a means to assess a patient's risk for diabetic foot ulcers and amputations. It also offers an opportunity for foot care education. All right, let's resume. Preventing diabetes-related complications. Lower extremity amputations, which is surgery to remove the toes, foot, or leg, are increasing in the United States, and 80% are a result of complications from diabetes. Hence, we're doing this webinar today for enlisting all you guys. Principles of podiatry care for people with diabetes. We treat fungal infections of the skin, we lubricate the skin, trim the nails, reduce the calluses. We treat the skin for fungal infections by utilizing topical antifungals for athlete's foot, otherwise known as tinea pedis. If this is for treatment of the nails, we consider oral antifungal medications for onychomycosis. We also utilize some oral agents for tinea pedis that is not responding to topical treatment. Lubricating the dry skin. It's mostly due from autonomic neuropathy, which contributes to the dry skin. We instruct the patients to apply a moisturizing lotion daily. Oil or water-based lotions are a matter of patient preference. I say that because patients sometimes ask me, what's the best lotion? And I tell them the one you use routinely. Caregivers may need to assist with these for some clients, and we do not recommend applying lotions between the toes. Trimming nails of normal nails. We ensure good lighting and a comfortable position using safety glasses or face shields. We use nail nippers, straight or curved. Stabilizing the toe with one hand, we cut with the other. We start at one edge and follow the curve. File any edges with emery board. In the past, I should note that in the past, there's been Dremels that have used in some offices. This is not recommended anymore, as you can aerosolize the fungus. Nail trimming, curved nails. We ensure, again, good lighting and a comfortable position, utilizing safety glasses or face shields. In the curved nails, we like to use straight-only nail nippers. We stabilize the toe with one hand, cutting with the other. Start at one edge and follow the curve. We avoid cutting into the corners, and again, file any sharp edges with emery board. Thick mycotic nails. Nails tend to be very brittle. We use to trim off the sharp edges, and if you have any difficulties, consider referring to a podiatrist or a certified foot care nurse. Callus trimming. Callus trimming is important in the fact that we actually consider these pre-ulcerative lesions, and that's mostly because you can get, especially on the plantar surfaces and any bony surfaces, it increases the pressure at that site and can break down the skin and the soft tissue underneath. We ensure good lighting again, using gloves and alcohol swabs and a number 15 blade scalpel. You can use other numbered scalpels. The number 15 seems to be a decent size, and that's the one that I prefer. We wipe with an alcohol swab. The callus will turn white. In this, you can also kind of gauge how deep and how much more you have to go when it comes to callus debridement. We palp, we shave, and pare down the callus gradually. Please keep in mind in this picture over here, those are not my hands, but in this picture here, the holding of the scalpel and the contralateral hand, you do not want any part of you to be in the path of a scalpel. So please be mindful of that. And when you're using a scalpel, try not to push the scalpel through, but more of a cutting action. And of course, like anything, practice makes perfect. We palpate intermittently to feel when you are close to a pliable, normal, quote unquote, tissue, then stop trimming. Wound management. In wound management, we need to have an assessing the wound, and we classify the wound. Evaluating patients with diabetic foot ulcers. We evaluate and classify ulcers with attention to wound classifications as described in Sinbad classification system. Using the Sinbad score or other diabetic foot ulcer classifications, other ones you may know of as the Wi-Fi, Wagner, etc., to communicate information with podiatrists, other clinicians, and consultants. The Sinbad classification, as you can see from this graph, is broken down into category, the definition of what you're looking for in the category, and the score of 0 to 1. Should be noted that Sinbad is 0 to 6 in total at the end, and a value of 3 or greater increases the risk of a non-healing ulceration lesion or amputation. The S is for the site. We look for ischemia of the wound, neuropathy, bacterial infections, the area of the wound, and the depth of the wound. Another classification, as stated, is the Wi-Fi, which is a wound, ischemia, and foot infection classification for limb threat. It should be noted that a lot of our vascular surgeons like to use this classification. Again, it's broken down into 3 categories of wound, ischemia, and foot infection, with grades of 0 to 3 in each category. If you get a score total at the end of 1, 2, or 3 or 4, it's usually associated with, as you can see on the right, higher levels of amputation rates. So again, more severe in one of these, and we cannot correct them, if there's more likelihood of amputation for the patient at the end. Standard care for diabetic foot ulcers. We need to ensure good vascular supply. We need to treat the soft tissue and bone infection. We initiate excisional debridement and maintenance debridements as indicated. These debridements usually, if you need it, are serial in nature and weekly on majority of the cases. High quality offloading is the cornerstone of diabetic foot ulcerations. To ensure good vascular supply, we need to assess circulation with an ankle brachial index. We mentioned how to perform that in part 1. and one other test. We can examine the skin perfusion pressure, the toe pressure, or transcutaneous oxygenation pressure measurements. If you don't have the tools and ability in your local clinic to do this, you can consider using a handheld Doppler or skin temperature sensor. And of course, always consider vascular surgery consultation if there's any concern for peripheral arterial disease. Here's a nice little graph that we demonstrate how the sensitivity and specificity of some of these tests that we perform in our clinic and in our service for ischemia in the diabetic foot. Palpation of a pulse. Should be noted that a palpable pulse is really associated with a high probability of wound healing. The ankle brachial index, ankle brachial index is good, and it's a good screening initially, but it's less useful for patients with diabetes, kidney disease, and diabetic foot ulcers. Toe systolic blood pressure. This actually measures the systolic blood pressure in the toe itself. And we're looking for, or should I say, toe systolic blood pressure less than 30 is associated with two-fold higher relative risk of non-healing after a partial foot amputation. And we really are looking for greater than 30 millimeters of mercury. When we're looking at transcutaneous oxygen oximetry, we're literally measuring the oxygen tension at the skin surface. And when we're doing this, the oxygen pressure greater than 25 millimeters of mercury is associated with a higher risk of ulcer healing. And of course, if not, then we're going to have a higher risk of predicting non-healing and limb amputation. Skin perfusion pressure, it's a measurement of the blood pressure required to restore microvascular blood flow after occlusion. Skin perfusion pressure greater than 40 millimeters of mercury is associated with a higher risk of ulcer healing. Again, it should be noted that these examinations, these tests may not be available to everybody in all locations, but we need you to be aware of them and be knowledgeable of them. Treating the diabetic foot ulcer in cases where there is peripheral artery disease, it's all about blood flow to these patients. Any ischemia is not going to promote any kind of wound healing. So timely revascularization is key. Restoring the arterial flow to the foot in chronic limb-threatening ischemia can really change the person's projection of their wound and the healing of their wound. The primary lower extremity amputations, this is when salvage attempts are not made. And on the side, if I may, I like the thought of save a limb, save a life. It's been documented very, very thoroughly that, and again, stated in part one, that amputations is a risk factor of death. And if we can mitigate that, we actually improve that rate. So if you're doing a primary lower extremity amputation, you have to select the correct patient. And that's with any surgical patient. You need to consider their lifestyle, if they're ambulatory or not, and how frail are all the comorbidities that sometimes come with some of these patients. If they're not good surgical candidates, or in some circumstances when they are not interested in surgical treatment, we have to find something, and alternative treatments for these patients need to be addressed. Surgical bypass versus endovascular therapy. I love it when I actually have the ability to have vascular surgeons perform either one of these paths, because there are pros and cons to both. Stating that historically in the literature, it does say that open surgical treatment is a little bit superior than endovascular therapy. Treating bone and soft tissue infections. We need to assess for the infection. We do this in many ways, but during our examination, we would consider an infection to be mild if we're less than 2 centimeters of the surrounding skin and superficial tissue being, erythematous and whatnot. Greater than 2 centimeters of erythema and can demonstrate cellulitis, and usually demonstrates involvement of the soft tissue, subcutaneous tissue. Severe infections usually demonstrated are systemic response to signs of fever and leukocytosis. Diabetic foot osteomyelitis is infection of underlying bone. Treating these infections, we prescribe appropriate antibiotics if the infection is present. Now, these antibiotics need to be ideally driven by cultures, so it should be noted that surface cultures are not very reliable, and tissue cultures is the preferred method of collection. Before those cultures come, you can initiate, to your discretion, empirical coverage of most of the common bacteria of a diabetic foot ulcer. Gram-positive organisms are the most common. These can include strep, staph, methicillin-resistant strains, and a lot of these can actually also have other organisms like Corynebacterium and whatnot, mixed infections in many of these cases. Severe infections and or deep wounds will require a more complex approach, such as hospitalization, surgical debridement, and IV antibiotics. This next couple slides, we're going to show you a logarithm of a management of active diabetic foot and the complications that can arise from patients that present with a diabetic foot infection. Initially, again, we look at the wound and we grade the wound. If next we look at if the wound has an infection versus not infection, and we can follow the arrows as it goes down the algorithm. If there's no infection, we check and see if there's ischemic tissue or vascularity area, so we need to treat that. It should be noted that in the diabetic foot infection, a lot of them are plantar wounds. Plantar wounds are a little bit different than any other part of the body because we're walking on them, and there's pressure that needs to be mitigated. So when we're doing the plantar wounds, we do standard wound care, and again, more importantly, is we need to have some kind of mechanism to offload them. The total contact cast is the gold standard out there to offload the wound. You can also do surgical offloading by such treatments as an Achilles tendon lengthening, stating that if it's not a plantar wound, then we try to do the wound care, and in some cases, even if we don't want any pressure, even if it's a dorsal, medial, lateral, we try to mitigate pressure on the wound. Follow-up usually on these wounds, when they're healed, you really need to do more of a surveillance because it's actually been demonstrated that a lot of wounds can return and they return in the same place. If it doesn't heal, however, we need to assess the systemic factors that can affect healing. You need to optimize the glycemic control in diabetic patients. You need to change some maybe optimized metabolic processes and give them the ingredients, if you will, for wound healing. We'll talk about that a little bit later with nutrition. Next slide here, we actually go into the infection side of the house when it comes to assessing the wound and then assessing the infection or not. Again, if you have an infection of a wound, you need to initiate therapy for the infection and treat the infection. After you treat the infection, or even while you're treating the infection, you need to also, at that time, check the vascularity, because if they have poor circulation, the antibiotics are probably not going to get down there very well. So stating that, if there's zero ischemic grade concerns, we test for osteomyelitis. A bone biopsy is the preferred method. If there is a deep infection, such as bone infection, otherwise known as osteomyelitis, you need to do wound debridement and preferably limb-sparing amputations. Sometimes prolonged antimicrobial agents are needed. If they do have ischemic changes, you again need to return to the wound care, you need to offload them, and you need to improve their vascular status by consulting a vascular surgeon. And after the vascular procedure is done, at that time, you need to assess the infection, again, deep-seated infection. Otherwise, you need to continue on with the standard wound care and bring you back to the other slide that we just had. Hopefully that makes sense, and hopefully you guys can go through this on your own after the presentation. It's a good algorithm. Initial excision and maintenance debridements as indicated. Uncomplicated wounds. Uncomplicated wounds, you know, some people have different thoughts on an uncomplicated wound, but you know, if there's no ischemic changes, if there's no infection, these are uncomplicated wounds. You know, you want to maintain a clean and moist environment for these wounds. You do perform wound debridements. You do regular dressing changes. That could be Q day, could be BID, could be TID. That's all dependent on drainage of the wound site. We need to offload the wound. We need to prescribe oral antibiotics, again, directed by culture. We need to continually monitor the size of the wound. And that's actually, of course, for good documentation, demonstrating, you know, progression of the wound versus decompensation of the wound. Stating that later on in this slide, we will talk about one of the criteria of using advanced wound products. But for right now, outpatient management is appropriate for uncomplicated wounds. Some patients who even have uncomplicated wounds but cannot be offloaded may need hospitalization. Debridement of the uncomplicated wound, you're really trying to remove the devitalized tissue. It makes way for healthy tissue to migrate in. You decrease the external pressure on the wound, and could be something like, you know, a hypertrophic tissue that keeps on putting pressure on the same side of the wound. And again, it will not heal when that pressure is there. And then, of course, with all of these, you need to mitigate the infection that potentially resides in the tissue. Debridement steps are as listed. You clean the wound, you remove the dead or infected tissue, and you clean and make way for the healthy tissue. You apply agents to mitigate infection. I should note in this picture, I do have a betadine swab in that. And you have to be mindful that betadine, straight betadine, like in the swab, is cytotoxic to wounds. So you have to use it judiciously. I'm not saying you can't use it, but it is, if you're using that regularly, you're not going to improve that wound. Wound dressing principles. Absorbent compounds are useful for soupy wounds. Hydrocolloid gels and occlusive dressings have a role in dry wounds. And of course, enzymatic debridement may be useful to soften eschar. Be mindful of eschar. You know, if you have a solid eschar, no fluid underneath, no leakage on the side, that's a stable eschar that you can consider being Mother Nature's Band-Aid, if you will. You need to monitor it. You need to, at that time, put betadine around that ischemic tissue to not let or control infection in the area. But if it's a soft or should I say fluid underneath and movable and whatnot, you need to remove that eschar. Dressing principles, wound dressing options. I should note, and if anyone's ever seen or tried to order wound products, it's daunting. There are a lot out there, a lot. And I hope that you can consider these classes and consider the classes and don't worry about necessarily the product name or anything at this time. We've listed these to have a hydration from less to more as directed by the color coding and the arrow. Hydrocolloids are occlusive and they trap fluid and they're good for minor burns and pressure ulcers. Silicone-based products are good for hypertrophic or keloid and for the elderly. Films retain moisture. These are good for grafts and surgical dressings. Hydrogels literally rehydrate and promote autolytic debridement and promote granulation. We separated these dressings and now we're going down to agents that have a less to more drying effect. Again, by class or category, we look at foams with or without silicone. There's both out there in the market. They're moderately to highly absorbent. And I guess that I really want you to be mindful. I've seen people try to use some of these foams which have a high absorptive property, but they're using them for some plantar ulcerations that they're trying to offload. These foams will not offload. You can squeeze them with your fingers, so you're probably not going to hold up very much weight with that. So please don't use the foams for anything other than the absorptive qualities that are designed in them. Alginates is our next category, and these are highly absorbent Exudate management with these agents can be very beneficial, and you try to optimize a moisture balance. Okay, with these alginates also, you can change them less than 7 days if they're stable and clean. But of course, depending on the drainage and if they're infected, you need to change them every day, or maybe even more than once a day in some cases. Hydrogels are highly absorbent. They're great for exudate management and moisture balance. They're similar to the alginates. Iodophores, these are used for infections, of course, because they have that component in them. They have been noted to possibly disrupt the bioburden on wounds. Cadexariodine, this is moderately absorbent, and it's very good. Interestingly, with this one, it's comes as like a gel slash paste, and when you put it on, it's kind of like brown. But as it absorbs moisture, you'll have the color change, and if it's really saturated, the brown will turn into white. In this way, it actually can be an indicator for you and the patient on the wound and what's going on in the wound, how much it's draining. Please take caution though with patients with thyroid disease, as the iodine's in here. Of note, the cadexar iodine is not cytotoxic. Providine iodine, our last and most drying agent out there. We use it to basically, historically in the operating room, you paint it with betadine. You have to let it dry. Once it dries, it creates an aseptic environment. Again, we can use it on the stable eschars there. Again, caution with thyroid disease and the fact that these are cytotoxic agents. Wound dressing steps. Make way for healthy tissue, debridement. Assess and classify the wound for dressing selection. At this time, you look at the tissue, the maceration in the tissue, the amount of drainage in the tissue. Is the wound draining serous versus purulent drainage? These can help you select the appropriate dressing material. You apply the agent to any agent that you would like that is appropriate to mitigate any infections, and then you apply the dressing itself. Adjunctive wound healing therapy. I kind of alluded to this a little bit more. These adjunctive wound therapies are cell and tissue-based products. This is regenerative medicine has been growing almost exponentially in the last 10 years, and we're making really great strides on it. Saying that at this time, there's definitely into the ideal advanced wound products out there. There are publications going on all the time. There was recently one by HRQ that was really good for tissue selection. Adjunctive wound therapy was also recombinant growth factors, platelet-rich plasma, negative pressure wound therapy, hyperbaric and topical oxygen therapy. I cannot say that all of these have the same risk-benefit profile. As mentioned earlier, nutrition is really critical with the diabetic foot ulcer. It's important to address the nutritional deficits of these patients. Our nutritionists, our dietitians are really great at giving interventions that can benefit with optimization of the glycemic control. They can also ensure adequate protein intake with teaching and educating our patients. Stating this, and I know I mentioned this, but I have to report that a concrete or unified recommendation regarding nutritional supplements are limited due to the conflicting published evidence out there presently. I would only mention that, you know, to heal these wounds, you need micro and macro elements for these wounds to progress in an environment that's had no infection or circulation that's been optimized. Offloading interventions for diabetic foot ulcers. Again, the total contact cast is the gold standard out there. It basically locks the patient in, and they're able to walk on the cast. Saying this, you know, this is a total contact cast. It actually has a lot of the pressure on the leg itself and kind of suspends the foot off the ground. So that way you really get minimal to no pressure on the plantar ulcers. If you can't have access, or you do not have access to a total contact cast system or an instant contact, a total contact cast, you can use removable cast walkers, knee high or ankle. It has been reported that if you kind of secure these removable walkers, that you do get a little bit higher success. It also basically has to be the patient's willingness to wear these. Footwear outside the cast systems are a half shoe, could be a 4-foot wedge versus a rear foot wedge type of shoe. Think about the surgical shoe that you may have in your clinic, a little bit higher, and there's a wedge or a removal of the front or the back to offload the front or the back of the foot. These shoes can be modified with an insole. Total contact cast. Your cast is applied every 1 to 2 weeks. You should have caution with patients with PVD. Again, with pressure, and if you're having too much pressure in a long location, you can have new ulcers develop. The total contact cast is the gold standard, as the healing rates is 70 to 95% with its use. A removable cast boot is 22 to 79%, and half shoes are 58% in these grade 1 and grade 2 diabetic ulcers. I'd like to point out that with the cast removal and changes 1 or 2 times a week, some clients can be very sweaty, or the drainage can be too much. You have to be mindful of that and change these casts according to each patient. Offloading interventions for healing diabetic foot ulcers. Non-removable offloading devices are more effective than removal of offloading devices. Plantar forefoot and midfoot ulcers healing rates and time to healing. That kind of reiterates what we had just mentioned, that if you use a total contact, which is not removal, you get a lot higher success rate. And if you do not, then you may not get as much as a success rate, because the patient may be less adherent to these walkers, because they can remove them. Again, patient education and bringing the patient into the treatment plan is really going to add to the success rate for these patients. Offloading continued. Barriers to the using of effective offloading devices is limited activity, restricted daily activities trying to restore normalcy, image and patient preference, and costs. This time with this slide, if we haven't mentioned you in this team, please know that you can be part of the team. Everybody's part of the team, but in IHS we just kind of put together a multidisciplinary foot care team. With this, as you can see, you need to have the administrators of your facility be involved in this and know how important it is. You need diabetic educators, dietitians, public health nurses, community health representatives, the clinic receptionists, primary care providers, clinical nurse specialists. More and more people are getting into the field of clinical nurse specialists, and I say hurrah. I hope more and more are coming on board. Physical therapists, podiatrists, vascular surgeon, and of course, central to all this is the patient. Stating this, not all of us have access to formulate a complete multidisciplinary foot care team, and sometimes you need to referral out for some of these services. The certification boards out there that nurses can undergo, and again, promoting certified nurse specialists out there. To have a certification board, there are 2 common out there, the WOCNB and the CFCN. Eligibility is you need to be a licensed RN with a bachelor's degree or higher. You need to have 24 credits, CME credits, specific to foot care in the last 5 years. And you need a minimum of 40 clinic hours under direct supervision of foot care expert. Then, of course, you need a certifying exam. Another board out there is the American Foot Care Nurses Association. And these certify people to be foot care specialists. Availability are nurse practitioners, BSNs, RNs, LPNs, OT, PT, MDs, DOs. The more the better. Continuing education requirements, at least 25 CEs and programs directly related to foot care, and this needs to be within the preceding 2 years. Completion of 30 hours of direct hands-on patient care, verified by a podiatrist, which can be the proctor or a certified foot care nurse proctor. They also need to have a portfolio demonstrating they have on-hands experience. 10 clients, patient cases need to be studied and completed by the applicant. And of course, completion of the certification exam. Clinical pearls in the diabetic foot ulcer treatment. Please take this first one at heart. We really need to treat the patient. I myself, sometimes, you see a wound when you walk in the room and you just kind of focus in the wound. Well, the wound's nice and all, but you need to look at the whole patient. You need to treat the patient, not the wound. You need to offload the plantar ulcers of the diabetic foot, as this is the cornerstone of diabetic foot treatment. You need to debride the tissue as necessary to enhance wound healing. Wounds can sometimes become quote unquote stalled, and serial debridements will actually turn a chronic wound into a more quote unquote acute wound. And so that way the body recognizes as a new wound again and initiates the inflammatory process again into the lesion. As stated earlier, recurrent ulcers are common and often seen at the same location. So it's important to be mindful and provide ongoing surveillance and appropriate protective footwear. The multidisciplinary foot care team provides optimal management of wound healing. If you get everybody on board to include, and especially including the patient, you will have a lot higher success rate when it comes to diabetic foot ulcer management. Those are our references. I just wanted to take a moment to say thank you to all the people that work out there so hard in Indian Health Service. You do such a great job. You're on the front line. And I really want to thank Indian Health Service themselves for getting this message, putting this product together, and taking care of all those communities out there. Indian Health Service is a critical part of our country, and I'm so blessed that I was part of it for so long. Thank you so much.
Thank you so much, Dr. Tran. We do have some questions in the notes section. Would you like me to read those to you, or do you want to navigate to that section and you can read them yourself?
If you would do that, Wendy, I think it will have a lot higher success rate.
Okay, great. So our first question is, getting diabetic shoes is a difficult process. Our NPs, nurse practitioners, aren't able to sign the forms. Only doctors or MDs can do them, and some people need them more quickly than others. Any tips on resources for diabetic shoes or ways to speed up the process to get a pair sooner than the time frame?
That's an excellent question. Thank you so much for the question. You're right. It can be a little challenging. It's gotten more challenging now than it was 10 versus 20 years ago, stating that we still need to be vigilant with that. I guess so as far as timing, there's actually, the timing is regulated. It's just part of the Medicare diabetic shoe program. You can only do that annually, and to my knowledge, you only get one pair. If you are a clinical nurse specialist, if you're a primary care, if you're anybody part of this team, having good relationships with these providers, be it your primary, your specialist, your podiatrist, your orthotist, people who these appliances, getting more knowledgeable and more practice in that is probably going to be increasing your success rate. NPs, to my knowledge, have to be, and please look at your own Medicare region for guidance. But in some locations, some instances, nurse practitioners can sign off on these. But to my understanding, they also have to be signed off with an MD afterwards.
Excellent, thank you. Next question was, are there any symptoms to notice before an ulcer starts?
That's a real good question there. As I mentioned, when we were looking at some of these pictures, and we saw that, and I see a lot of times, it's, some patient might just come in with a callus, right? And so There's other things that we need to look at. If it's just a callus, we do know that this is devitalized tissue. A lot of times it's hard. It's like you're walking on a stone. The stone doesn't get hurt at all, but all the soft tissue and the skin and the pressure and the repeated trauma is going to break down the soft tissue, and that's going to lead you more and more into eventually into an ulcer. Um, that's something to be mindful for. With these, you also need to take into consideration again patients, how should I say this? Patients' skin quality. If you're elderly, if you have poor circulation and thinning skin, if you have neuropathy, which can affect the skin itself also. There's other factors, but when it comes to these ulcers, I would just say, in general, if you have a patient that's diabetic, especially poorly controlled for an extended period of time, and of course, especially comorbidities, you really need to have a high level of suspicion.
Thank you. If you were ordering a basic set of, hold on, let me pop this out so that I can see it. If you were ordering a basic set of dressing supplies to stock in a primary care clinic, what might you recommend?
Wow, that's a good one. Stating that, as I mentioned earlier, it can be pretty daunting, and to look at some of these products out there. There's a lot of them. I recommend that you look at the classes. I recommend that you look at your own clinic's um, frequent flyers, if you will. I mean, these don't have to be. If you're looking at supplies and you have it like a wound nurse, they may not just be doing diabetic foot exams. They may be doing post-surgical exams and whatnot. Stating that, I would like to encourage you to have at least one category of a drying and one category of a hydrating product out there. The hydrogels have been really good out there. While you're asking this, we didn't really mention it. For a lot of patients, when it comes to wound cleaners, we can't support any one out there. And I've actually asked the CDC when it comes to these products, they don't have any recommendations. The literature basically says soap and water out there for most of these wounds for patients in home care. If you do feel like they're in need of the wound cleansers out there, that's usually when you have a more complicated versus an uncomplicated wound. I hope that helps, because that was a really good question. Our administrators don't really like to have products that go out of date. So be mindful of that.
Excellent. The next question is, in a person whose ulcer has healed, how often should they be reevaluated?
Wow, that's a really good question also. When it comes in, and part of this was in part one, is that, risk factors, you assess the risk factors. If someone has diabetes, but they're well controlled, they don't have any deformities, they don't have any lesions, they don't have any additional risk factors, that's yearly. People with neuropathy and stuff, that's 3 months. A healed wound, looking at the wound and educating the patient, that healed wound, quote unquote, closed, is still not as strong as the surrounding tissue and skin that is not been injured. So time also improves that ulceration location. So being mindful of that, offloading that area, maybe in some patients, depending on risk profile, could be anywhere from 1 to 3 months.
Okay. Excellent. Thank you. The next question is diabetic socks. Are they worth paying extra? Are there any low-cost options?
I think if you ask any patient that wears them, they love them. I support diabetic socks. A lot of our clients have microvascular disease. They have um, venous and arterial disease. You got to be mindful of how much constrictions on there. I guess I can say I like them as far as cost effectiveness from patients that I've seen, that they swear by them. So I can only give you anecdotal answer for that one.
The next question is, do patients need compression when healing any wounds or to prevent wounds?
That is a good question, and that's a really excellent question when it comes to venous stasis ulcers or venous wounds, where those are really only going to heal with compression, along with all the other all the other agents and topics and addressing of risk factors. In an arterial compromised wound, compression is not your friend, and you need to be mindful of that, because even pressure can degrade skin, and because pretty much you're making the microvascular to the skin, they're not able to perfuse, so you're going to have degradation of that tissue.
Next question, could you comment on how to identify a callus that might predispose to an ulcer?
Well, I will say to you, a nice firm callus that's and especially if you've seen them for repeatedly, you can say that that's and managed well. That isn't too bad. But let me say that if you see a callus with some maybe subdermal hematoma, some blood collection underneath, it could be petechial or it could be an actual little hematoma under there. Those definitely need to be mindful of those. Those can lead, I feel, a little bit higher risk for the ulceration. Stating this, in the picture that we showed with our patient's heel in this video earlier on, we haven't mentioned it here, but deep contusion type of tissue damage when it comes to these ulcerations, that's not a good sign. If you get some bruising of the deep tissue, you're going to be really expecting a wound to be coming at that time. Hopefully that helps.
Yeah, let me, the next question I think I can take. Would you consider doing a future webinar on diabetic neuropathy of the feet? You mentioned neuropathy, but interested in what patients can do for pain. We do have a recorded webinar up on our website, Diabetes and Neuropathy by Dr. Badir. But Dr. Tran, if you want to fill in or if you want to answer that real quick, we could do that too.
I'd love to. Thank you very much for the opportunity. You know, that is a hard topic, and I do encourage people to look at that WebEx. For my part, you know, we do get a lot of patients that come in like that. A lot of these patients also have a lot of different medications on board already, so you got to be mindful of some of these agents that we give them, saying that some of these medications I have seen better improvements. Sometimes you use first line medications, these neuroleptics, and then you kind of increase, you know, like some people like to start with, you know, many of us like to start with gabapentin and then maybe increasing or adding on amitriptyline, or could be Lyrica or something like that. You really need to look at the systemic presentation on that. Stating that alternative strategies that have heard have had variable benefits is acupuncture. Note that vascular can have an impact on neuropathy also. So if you can correct the patient's glycemic control or optimize the patient's glycemic control, optimize their circulation, giving them an environment that nerve can thrive, that's probably going to be good. Again, you need to assess why, right? You know, it could be vitamins like vitamin D, B12, could be thyroid. You need to do a good examination for giving you a better path for that.
Excellent, thank you. Received a question. What roles do honey, urea, and Dumboro play in foot care?
Thank you for the question very much. Let's see, Dumboro, you know, it's good. We used it in our old clinics. People have variable interest in it. I would say it's a safe product. Again, with diabetics, you know, when you're sticking their foot and getting it moist, please encourage them to dry the foot thoroughly. If they can't reach their toes, some people have told me a blow dryer works really good. Urea, you know, urea is really good for hypertrophic tissue, you know, and you just got to be mindful of it. Urea comes in variable strengths. You know, you got 10, 20, 40. I've actually seen urea 40 fully melt down a nail that's like a half a centimeter thick. So you got to be really careful with that stuff. And it was urea, Dumboro, and what was the first one?
Honey?
Honey, they've been using honey since the Egyptians. There's good evidence on that, stating that I do feel like there are other products out there that may have some higher success rates. I'll say that.
So thank you. Next question is, what fungal treatment is recommended for thick fungal nails?
Thick fungal nails, I'll give you my spiel. Every patient, I tell them that there's 5 different levels of treatment for that. Um, at the beginning, on level 1, let's say, we're going to have the over-the-counter products. Level 2, we'll have prescription-grade products that are topical in nature. Level 3, we'll have oral agents. The level 4, there's use of lasers out there these days. I do not recommend that. And then there's number 5, removing the nail and starting over. Stating this, if you remove the nail, you need to treat the darn thing anyway. If you're using an over-the-counter, and some patients don't have access to our facilities and they don't have the monies, Vicks Vapor Rub, actually, just a Q-tip, dip it in the Vicks, which they can have at their bedside, putting it onto the toenail. Don't smother it all over the skin. The skin won't like it after a while. But you do that consistently for 6 months, and that has a decent success rate if nothing else is available. Topical agents, we use agents like cyclopirox, otherwise known as Penlac. Patients have told me that they've tried that and it didn't work before. If you try it and you start someone on that, please encourage them to use it as directed, applying Q day, Monday through Saturday example, removing all the layers on Sunday. 6 months is the key. If they stop in 3 months, they've wasted 3 months of their time. Stating that, I think Lamisil is still the gold standard when it comes to antifungal oral agents. It's 90 days worth of treatment. I should warn that the product label does say and does recommend that we do an LFT on day 1 and on day 30. There's anecdotal practices out there that says that you don't need it, and there's some literature says that you don't need it. I myself am going to follow the product label until they change it.
Good recommendation.
Yes, ma'am.
One more question, well, a couple more. Do you recommend elevating feet whenever possible, or is it not necessary for diabetic patients with foot complications?
Well, I, I can't, I don't know how to answer. I can't say it's a bad idea. I mean, when my feet are sore, I like to elevate them, but for our patients, I don't know if it really has a too much of a factor. If you have peripheral arterial disease and you have them in a dependent position, their feet can get dependent rubra. You'll see like them turning a little red, and you elevate them, they return to normal. That's actually a sign of peripheral arterial disease, and you need to address that. Stating that, if you do have that, I can see that someone sitting up in a chair or a wheelchair all day, the I use this analogy, water runs downhill, and so it's the arterial as you go down, that doesn't seem to be a problem with good flow. If patients with comorbidities of, let's say, venous disease, you're going to need to mitigate that because back pressure and poor forward pressure is going to not give you very good microvascular perfusion. So to make a simple question more complicated, be mindful to not keep them in dependent positions for extended period of time.
Excellent. There was a question, what are some good over-the-counter products to tell patients about?
I in relation to antifungals, in relation to can I get more information? If it's antifungals, my favorite out there actually, and you see all the commercials on TV. By the way, they have to pay those commercials somehow. I don't feel any of them. I haven't seen any of them work for onychomycosis. Stating that if someone can tolerate it and are good candidates for oral therapy, if they've had it for years, I actually encourage them to do a 2-prong inside and outside approach or attack towards what you're trying to get to, which is a recovered toenail.
She said keeping foot healthier treatment. So
keeping foot healthy or treatment. Well, good over the well, you are asking a podiatrist, so I would say uh, any really more of us need to be more mindful of our shoe gear. You know, I just have been practicing on the West Coast for the last 20 years, and I got to be honest with you. You try to tell somebody to stop wearing sandals, it can be a little challenging. But you know, you work with the clients that you're working with, and you try to create a more optimized patient, right? You know, deformities, for example, which we didn't touch on too much, deformities don't get better with time. They usually get worse with time when it comes to digital deformities and whatnot. So having good supportive shoe gear will a lot of times mitigate a lot of these complications later on. As far as different products on creams and stuff like that, I don't think I can comment on that.
Thank you so much. There is one more question, but we're 3 minutes past the hour, so I'm going to go ahead and advance the slides, and then we will come back to that final question.